The issue of anticoagulation and atrial fibrillation in patients with chronic kidney disease is still very controversial. There are really two major clinical issues related to atrial fibrillation in this population, and they're similar to the general population too, but essentially the stakes are higher. The first issue is the risk of systemic embolism, specifically ischemic stroke. From a patient perspective, I think that most patients would agree, and certainly mine would, that things that they're most afraid of, probably stroke is at the high end of the list, would say that it's actually worse to have a disabling stroke than it would be to die because of the loss of autonomy and quality of life. Second issue is everything has a price. Risk of agents to reduce the risk of ischemic stroke really is related to hemorrhagic risk and major bleeding. The population of patients with chronic kidney disease are particularly challenging because the risk of ischemic stroke is higher, related to diminished eGFR, and unfortunately, so is the risk of serious hemorrhage. Advantage of anticoagulation is the reduction of risk of stroke versus the serious complicating risk of serious life-threatening bleeds. If we go way, way back, more than 20 years to the SPAF trials, SPAF3 was not designed to look at, again, at CKD patients. The SPAF3 design were patients that were either low-risk patients that were put on aspirin alone or higher-risk patients that were randomized to aspirin plus low dose, or what we would say is ineffective dose warfarin versus INR-adjusted warfarin. Of interest to me as an investigator and looking at the SPAF data years later, in SPAF3, there were enough patients with stage 3 chronic kidney disease to do a reasonably robust post-hoc analysis, which was published actually in CJASN 2 years ago. So what are the lessons that we have to make clinical decisions at the present time? We really don't have a true randomized trial that was designed to answer the question of whether patients with CKD of any stage should receive anticoagulation or not, because that wasn't the intent of these recent trials. So what we're forced to rely on, it's not bad, but it's not totally satisfactory, is post hoc analysis of patients with CKD who were entered into clinical trials. In the last several years, there were 2 papers that were published that gave some concern to clinicians, including me, about the safety of use of warfarin in patients on hemodialysis. And one was a paper that was published by Chan and colleagues using the Fresenius database. And their publication reported a increased hazard of stroke related to increased intensity of anticoagulation with warfarin. Now the problem with the data is that it's small, it's observational and potentially confounded, but it was the best we had, and that was actually one of the main reasons why the KDIGO Controversies Conference recommended a change in the practice guidelines from indication that warfarin should be used for primary prevention of stroke in dialysis patients with Afib, and we softened the guideline to be really, we don't know, so clinicians should basically decide what they want to do on their own, and we're not telling them to do it or not do it. Recently, though, perhaps the pendulum has moved the other way, because now we have 2 observational studies that indicate some benefit from warfarin in hemodialysis patients. The first was published by Olesen and colleagues, a recent New England Journal paper from a large Danish cohort registry study, and of more than 140,000 patients with atrial fibrillation discharged in Danish hospitals. A small number of these patients were on hemodialysis, I think about 900 actually. But what was interesting is in this Danish cohort study, there was a strong protective association related to warfarin and systemic embolism. We now have a new observational study that sort of cancels out an older observational study. And finally, from work that I've done at USRDS with my colleagues, we presented a large observational look from USRDS registry data, looking at nearly 20 years of rates of ischemic and hemorrhagic stroke related to warfarin use over time. But the thing that we found is that as warfarin use has increased over a period of more than 15 years, there has been a concurrent reduction in the rate of ischemic stroke. In the general Medicare population, you see the same thing, where over a long period of time, the use of warfarin goes up, the ischemic stroke rate goes down, and the hemorrhagic stroke rate doesn't change very much. It's probably the best real world example of the dissemination of clinical practice and outcome data from clinical trials into real world practice. Now, in the hemodialysis population, you see something similar. When you look at the same type of methodology, the same pattern appears where as the use rates go up, there is a stepwise reduction year by year in the rates of ischemic stroke, and not much of a change in hemorrhagic stroke. It doesn't prove causality, but it's hard for me to believe that if this drug really was causing stroke, that we would be seeing a reduction in stroke over time with use of warfarin increasing. My overall assessment that there's reason to think that patients with stages 3 and 4 CKD would benefit from primary prevention strategy using anticoagulants. In contrast, in the hemodialysis patients right now, I think the issue is still open. I think the clinicians still have to decide at an individual level what to do. A patient who appears to have a high clinical risk based on factors related to age or previous history, other comorbidities, of being at higher risk of ischemic stroke and not being a very high risk for hemorrhagic stroke probably should receive primary prevention with anticoagulants. Secondary prevention, I think the issue is that probably everybody should, unless there's a compelling reason not to.